We will be getting started here in just a few moments for NCA Coffee Club on October 14, 2023. Just waiting for people to come and join us here. Well, hello there, everyone on Facebook Live. Grab a cup of coffee and join us. We're going to have a little meeting of the minds here, the NeuroCentric approach online coffee club. All right. So welcome everybody. Thanks for dropping in for our NeuroCentric Approach Coffee Club meeting. We are coming at you from two directions today. Over here, we've got the over-the-shoulder look. And over here, we've got the Zoom look. The Zoom look is for members at the NeuroCentric Approach Online Academy. Although I see Catherine Rohde is over here because Facebook Live is a little easier over there, isn't it, Kath? And looks like Jerome Fryer is showing up with us here as well. Good morning, Jerome. And he's got a new model that he wants to show, and just buzzed that past me a bit ago, and I noticed that the model is along the lines of a case study that I wanted to talk about, instability and some other issues from a case that I had this week that I thought would be worth discussing. So Let's see what's new this week as folks are coming in. And my world, my wife is hiking Hadrian's Wall in the UK. She's over there for a trip all by her lonesome. And my doggy and I are getting some batch time this week and next week. But she's enjoying a nice little end-to-end kind of walk across Britain. Yeah, it's kind of cool. Let's see what else. I have some of you that were on here last week saw my son with us, and after that we went out and had a lovely walk around in the woods on a beautiful fall day. And the chanterelles are up at 1,000 feet in the Columbia River Gorge. We got about 6 pounds of chanterelles and had a real nice feed that night. Let's see other things. There is apparently, even right about now, a partial eclipse going on, although you wouldn't know it here in Portland because it's cloudy. I guess down where you are, Catherine, you'd probably be able to poke your head out in about 30 minutes or so and see a solar eclipse. Don't look at it. Don't do that. Go online first, get some glasses, or figure out how you can do it safely. Don't bake your retina. Other things we have a fascinating world situation right now with the Hamas invasion of Israel a couple of days ago or a week ago, and just is an amazing time in the world right now. My heart goes out to all of my Jewish friends, Israeli friends, and to all of the civilians in Gaza that are dealing with the tumultuous times that are going on there. Hope we can find our way on the other side of this crazy conflict-laden time that we find ourselves in at some point in the not too distant future. Okay, on slightly more on-topic items, I thought today a topic of conversation I would lead into with was an interesting patient that I had this past week. I will pull her chart up and get it in front of me so that I can chat it out. This was a patient referred over to me by an urgent care doc who is former resident of one of my colleagues who runs the family practice residency program at Providence. And so he's known of me for some time, and I've been working with him now for the last several weeks with a back issue that he's got. He had a prior history of a lumbar disc from several years ago that he rehabbed effectively, but he was struggling with some ongoing pain now that he is a father and has I believe his child is about 8 months old now, and another one about a year and a half old. And he's not getting very much sleep. So we can imagine the interleukin-6 concentration is relatively high in his body. And he has near constant pain in his right lower back. And that right lower back pain on evaluation, I could palpate it, and it correlated to the middle branch of the superior cluneal nerve on the right. It was so cluneal neuralgia was not something that was in his zone of reference. So we've had a good time working with that, and then following up with some DNS work. He's been impressed with the results there and sent over a patient this past week, 40-year-old female who moved to Portland several months ago with her husband from Boise, Idaho. Shout out to Dr. Ben Ramos over there in Boise. She had a pretty interesting backstory. She's had right lower back pain, posterior hip pain, and right leg, what sounds like history of sciatica for the better part of 12 months. After, as part of her moving, packing boxes and everything, almost a year ago, and she recalled trying to lift a box that weighed about 150 pounds or so. And she felt something move in her back, according to her. And she had exquisite pain at that particular time. Over several weeks, it got a bit better, but she's had some level of sciatica in that leg up until that point. And then once again, about 2 weeks ago, she had a really intense flare up, what she referred to as worst pain ever in her right anterior leg over her tibialis anterior area. And that's what caused her to present to my doctor friend urgent care. She was given a course of prednisone, which seemed to help. After about 3 days, those symptoms were essentially resolved. Past health history is deep and wide. As I mentioned, 40-year-old female, 2 children, but one still alive. So a tragic story there. Her 12-year-old child died in a rollover accident in a car that was submerged, and he drowned. So she had that trauma in the last year. Her brother-in-law was murdered. She's got that trauma on board. She is a type 1 diabetic. Lifetime. She is well managed there. She's using a Dexcom continuous glucose monitor with an onboard insulin pump. So sort of a plug and play solution that works quite well. She's got a frozen right shoulder. She's got a bleeding disorder, a protein S deficiency. She's had a prior history of deep vein thrombosis. She is hypertensive. She was diagnosed with acute myelogenous leukemia in 1998. Let's see, she's had gallbladder and appendectomy, 2003. She had chemo in that leukemia episode in 1998. Let's see, what else? Full hysterectomy, 2013. Bilateral carpal tunnel release. She's had eight trigger finger releases. 8 trigger finger releases in the last 2 years. She had a left second toe joint removed due to chronic pain and a failed fusion. And she's had 9 eye laser procedures for diabetic retinopathy. Quite a deep history there. Let's see, she's also on adaptocrine for low cortisol. So she presented with ongoing intermittent pain in her right posterior hip, thigh, and leg, which are a lot better than they were a couple of weeks ago. And one thing I forgot to mention, she didn't mention on her intake, but it became apparent when I started getting her to move around. She was reluctant to lay on her back. And as she was reluctant to lay on her back, I asked why. And she said she gets vertiginous when she lays on her back. So I asked her if she would mind demonstrating to me the process that seems to make her feel that way. And she had no problems laying face down in a prone position. But when she rolled over onto her back, she could get down onto her right side. But as soon as she rolled over onto her back and got beyond midline, she would start to feel vertiginous. So I put on my vertigo hat and got her up, sat her on my swivel chair, a swivel stool, and I blocked her head. Some of you might have seen, I've got on my YouTube channel a patient that I worked through this rubric, which is the assessment of peripheral vertigo up to Epley maneuver. So you can check that out on my YouTube channel. But the swivel test, block the head movement while the patient's looking forward, and then have them, as I'm doing here, walk themselves all the way to one side and then to the other. So you've got effective end range rotation in the cervical spine to the point that she could not move any further. And she was not able to reproduce her symptoms doing that. So the idea there being we are trying to isolate the labyrinth, the vestibular apparatus, and tease out the joint mechanoreceptors in the upper cervical spine and see if we've got any feed forward problems there that could be contributing to that. So we didn't have anything there. So next stage in that process, typically, since it's important to note she had a rapidly extinguishing pattern of vertigo, her symptoms last just a few seconds, and what she had learned on her own was that she could make them go away just by focusing very strongly on something and by doing deep breathing, which she had noticed a correlation in her vertigo symptoms with stress. So that was kind of interesting. And given her prior history of trauma, that brought up some ideas for me. So the next place I would typically go in that out of that assessment is a Dix Hallpike maneuver, or get her to lay on her back with her head fully rotated and extended, and the neck and to the right and to the left. And she could do it to the right. And as soon as she started turning to the left, she reported feeling really vertiginous and really nauseous, and was concerned she was going to throw up. However, she exhibited absolutely no nystagmus, and she demonstrated to me that she could extinguish the symptoms in less than 30 seconds. So that's leading me to think that we're dealing with some sort of peripheral kind of issue, or at least away from a centrally mediated issue at the brain that we need to do some sort of red flag rule out issue on. So I pulled a page out of the graded exposure therapy in the world of psychology and tried to help her establish a bit of agency. She had noted that she could lay on her back with her neck flexed, and she could turn her head to the left fully without symptoms. but if she let her head go back towards neutral and try to do it, she would get symptoms. So in the in some types of psychological treatment for exposure therapy, and I'm privy to some of this being married to a psychologist, but this type of graded exposure in trauma patients, typically the trauma, the patient has some sort of an idea about the things that might promote their trauma, the mental thought processes and such that might promote the trauma. And those patients will then be instructed on how to use deep breathing mechanisms to reduce the physiological effect of the trauma. And then the patient will be coached through something, in this case, sympathetic upregulation, breathing into a paper bag to change blood gases and get them a little bit sympathetically aroused. In this particular patient, since we knew that she could provoke her symptoms, we went right up to the edge of that. But first, we coached her through deep breathing, 4 seconds inspiration, 6 seconds expiration, where the best evidence tends to oscillate around the improvement of parasympathetic tone and down regulating the sympathetic tone. And at that, we then started to move her into the provocation position. And as her symptoms came on, I stayed there with her and coached her through the deep breathing, and also through some oculomotor reflex material that I learned once upon a time many years ago from Feldenkrais movement therapy. And we worked on soft gaze into the distance while she was doing that. Incorporated DNS principles of leading the movement, because she would not use her eyes with the rotational movement. So I had her to initiate the movement before her symptoms began by looking as far as she could to the left, her provocation position, and continue to look around the corner there to the left as she did it. And lo and behold, we were able to get her to go all the way into several repetitions of turning her head all the way to the left. And the fascinating part, as some of you pain science geeks are already waiting for the other shoe to drop on this. The fascinating part is after we did that, and I wasn't anticipating this, her leg pain and back pain were much improved. So her symptoms in the back of the leg, she had an x-ray, a 3-view x-ray done at the urgent care facility, which demonstrated, let me get this right, let's see, she had a 4 millimeter anaurosthesis of L5 on S1 and a 4 millimeter retrolesthesis of L4 on L5. And she reports that she's got some sound, some clunk out of her back when she moves. So as I mentioned, her x-ray was a 3-view x-ray. We've got a patient with essentially some sort of interesting connective tissue disorder history. On physical exam, she appears to be hypermobile in most vectors. I would put her at a Beighton 6/9. And I on her instability tests, she was positive 3 out of 3 for the prone lumbar extension, the supine flexion test, and also McGill's prone instability test. All of that making me think that the presenting sciatica that she's been having for the last year is likely due to some foraminal and narrowing owing to the changes there from the listheses that are going on. So we got to now go get another x-ray that shows us the status of the stability there. We do a flexion extension study and also an oblique to try to see what the status of the pars interarticularis is. We could do a MRI follow-up if the pars looks like it is challenged with the stir echo on the MRI to focus on that a bit better and learn more about the pars if that's the case. But interestingly, on slump test, on SLR, no symptoms. She had restricted range of motion, but no real symptoms, and I was not able to modulate her symptoms on slump or SLR with neck and ankle movement. So interesting case. I'll keep you guys posted on that. Let's see, it looks like Jerome has dropped off of our list there. I think it's worth noting as well, for those of you that are coming on here unaware, especially over here on the over the shoulder with Facebook Live. This is the NeuroCentric Approach Coffee Club, and we're talking the NeuroCentric Approach. And we're talking about the online academy that has been out now for a few weeks. Those of you that are unaware of that, please feel free to join us there at academy.neurocentricapproach.com. I think there is a link. Yes, it should be coming up on the link right now on Facebook Live, but it's academy.neurocentricapproach.com. So I would encourage you guys to come and join us over there. The price is stupidly low. You've got, I think we've got about 30 hours of online continuing education that's recorded there. And that is PACE accredited for chiropractors for continuing education. And you got 30 hours available to you. You can pay for it by the month, or you can pay for it by the year to have access to it. So if you just need to get your CE taken care of in a short period of time, pay $39 right now while we've still got that offer in place, and you can go there and get some continuing education as much as you need for the ridiculously low price of $39 and change. And or if you just want to pay for an annual membership, you can save about $100 or so by paying for it annually. Periodically, for those of you that are lifetime members, I'm going to toss that out there as well, so you guys keep your eyes peeled for that. Periodically, we'll throw some single time payments for one flat fee, and you can get lifetime membership to the site. I'm steadily adding content on about a monthly basis. I put another piece of content out there, and what I'm investigating now is also building an app for the NeuroCentric Approach that the way I'm conceptualizing it, and I'm open to feedback from those of you that are involved here, but the way I'm conceptualizing it is it'll look a lot like the original YAP or DTM course, where the way that I could conceive of it being most useful is, let's say you got a patient that's getting ready to come in and they got shoulder pain, and you just wanted to very quickly review what it is from a neurocentric approach vantage point that you need to focus on. So you find a map or a picture of the body, and you poke on the shoulder, and shoulder detail for NCA would come up, and the details from the shoulder course that is in the online site would pop up for you there. And your nerves of suspect, the suprascapular nerve, the radial nerve, the axillary nerve, all of those, and the dorsal scapular nerve, all commonly involved nerves with shoulder complaints would be reflected there. It would talk a bit about the ways that you could use DTM or transverse nerve mobilization to offload the nerve or try to work on a putative interface area. So you get a manual prompt, and you'd also get a bit of functional exercise recommendation as well, and some home care to address the structure that's actually talking. So that's in the works right now. I've got to get that out of the gate for the Fix Your Own Back program, which is also online. And I'm just building the app out for that right now as well. So eventually we'll have, actually that app is built out and is now available. The Fix Your Own Back app is now available on Apple and Google on the App Store. Whoop, whoop. So do we have any comments or questions from any of you folks over there on live? Or from any of you folks over here on our Zoom meeting? Okay, so I see Michael Holstein, Josh Paloma, David Brown on. Welcome, guys. Appreciate you joining us today. Josh, I hope you're well. It's nice to see your text representation of your being here. If you guys don't have any specific questions, then I will call it a short one today then, and we will reconvene next week. Those of you that are were unable to join us today can check in on the at the end of this. You can find us at the recorded version at the online community. Actually, I'm seeing Doris Merton show up, and Doris has been trying to get in for a while. So let me stay on here and see if we can chat with Doris. Doris, welcome. It's nice to see you. So unmute yourself there and chat me up about Toronto. How are things going?
No, I was listening to you on Facebook. Thank you.
Very good. Very
It's
good.
nice to see you too. I've been listening to you on Facebook, but this is the first chance I had to get to my laptop to get onto Zoom.
So I know we had some difficulty before, I think because of my own ineptitude in trying to get the links properly shared out there.
No,
So
this one worked perfectly fine.
perfect. Then I think your coaching there and the things that you had learned was what I needed. Apparently, I was just going on to Zoom instead of going specifically over to my the actual event that were saved on Zoom that was being sent out. So good. I'm glad to see that worked.
Much appreciated.
and Jerome is back on as well, and he is so we're well represented by Canada here this morning. Because Jerome's in Vancouver or Kelowna, but you guys have got a new citizen up there from my household. My son just got Canadian citizenship last week or 2 weeks ago now. So I gave you my best and brightest. So what's new in Toronto these days?
I just had to mute myself. Nothing really. I mean, I think all major cities are still sort of. I work right in the downtown core, still recovering from all the craziness from COVID. Still not quite what it used to be,
Yeah.
but it's slowly coming back.
Yeah, I understand how you feel. I mean, it's mostly back to normal here, but like the certainly the continuing education, in-person kind of stuff is still lackluster, and it's part of the reason why I put the online site together there. Have you gone on and checked out any of the online coursework?
I have. I've done a couple. They've been great. I've been
And
slowly integrating
give
them.
me some feedback on that. What could we do to make them better?
Uh, I actually really quite enjoy that. I haven't quite finished the fix your own back. But I did do, what did I do? I did the knee, and maybe the ankle and foot. I know you had mentioned once that you're considering on these chats, maybe, walking through the full nerve. That would be really interesting
Okay.
to do.
Okay.
Uh,
That's a yeah, I think the way that this process is likely to evolve over time is we'll have a variety of different um, ways to access the information. One, I think you may have caught over on Facebook Live a moment or so ago, but I was talking about the app that I'll build out at some point in the not too distant future with
I did.
all the extra time that I've got. Um, but the idea being to have something that's a ready reference that you can very quickly get, all right, this. I need to keep that in mind with this patient that I'm getting ready to see versus bite-sized courses on the site that are an hour to an hour and a half long, uh, possibly even a micro course in between of length. I'm thinking about it in the way that most of us tend to behave, and we tend to have certain little time blocks that we're free, that we can be able to check some of this stuff out, and then longer courses available online that are 8 to 12 hours, and then finally, of course, the in-person courses where we'll be able to get people's hands working a bit more again and be able to actually feel what it is we're talking about. And Justin and I can come out and teach coursework in that as well, or both of us if numbers warrant, or just Justin will come out and teach that as well. So the I'm thinking that in between micro course kind of thing is probably something along the lines of what you're talking about. So we isolate one specific nerve and say, okay, this is where it comes off of the spinal cord. This is a spinal derivation. This is the actual course of it. This is how the course is challenged or mechanically challenged mechanically, or you have potential interface issues along different aspects of it, et cetera, et cetera. Yeah, I think that could be fun.
I'll also just say I really
Um,
appreciate all the references that you give, all the research. It's been great just to hear all of that again, or be updated. So much appreciated for that.
Good. Thanks, Doris. I really appreciate the feedback there. Yeah, a lot of work goes into this,
I'm
and
sure.
it's and hoping that a few folks, if you want to do something out there on Facebook, share this with your friends and in your feed so we can get a few more people consuming this. Jerome, you've got, do you have your ears on there, mate? Jerome this morning had we had mentioned he was sharing with me a paper. Let me unmute him. Sharing with me a paper about lumbar instability. Talk to me, Jerome. What do you got on your mind there about that?
Oh, I think it's just I think it's extremely common finding that often we don't have the diagnostic capabilities to discern, the specificity, but these little movements that cause patients pain, in particular when the spine is moving. I just think it's, I think for the most part, we're on to it, right? But sometimes it's a little difficult communicating that to a patient. Like, how do you help them understand, oh, it hurts, and what does that look like, and what do you do to mitigate that sort of thing. So anyways, I just thought that was interesting, that just came across my my feed there on my the searches that I have on auto there every week on when Saturday morning. It comes in off PubMed, and I've got certain keywords that I'm kind of dialed into. At first I had a whole plethora of keywords, and there was too much to sift through, so I kind of narrowed things down so I could be a little bit more I don't know, just a little bit more. You can't read it all, right? But you got to sort of read the stuff that's pertinent to you, you'd think, or at least what you hone in on in clinic. So that's all.
Yeah, I've got the same thing. Now, for those of you here, the paper that Jerome is referencing is a brand new paper that admittedly I haven't read yet. I'm going to throw you the PubMed ID number as well that you can search. It's 378-10286. So if you just go onto PubMed and put that PMID number in, the paper will pop up. The paper is called Facet Joint Thickness and Lumbar Instability, documented on myelo-computed tomography studies in patients with lumbar degenerative disease. It appears to be a Japanese study, appears to be all Japanese authors here. Looks like at cursory view, it's 120 patients, 45 with lumbar degenerative spondylolisthesis. So that patient that we had on the case study that I was discussing earlier, that would be one that we would be interested in, possibly applicable there. And 75 patients that had lumbar spinal stenosis alone. And the myelo CT findings were indicative of indicative of instability, which included facet joint thickness and facet tropism, fluid in the facet joint. Yeah, this is fascinating stuff. I'm recalling as well in the Fix Your Own Back course, and Doris, I think you might have been at that course when I taught in Toronto, but there's a paper that Michael Shacklock brought to my attention a number of years ago that both of us were very intrigued by Dombrowski, where they did a CT. They had, I believe, if memory serves, they had CT set up on patients and had them go through full flexion and extension. So as you know, Jerome, we would typically try to clinically rule in or out an instability issue in the lumbar spine. We do a flexion, lumbar flexion lateral, and take a still shot, and then have them do an extension and take a still shot. But what we don't know is what happens in between. And that live CT that Dombrowski did, that was incredible. Those of you that are on the online academy for NCA, that course, the clinical companion to Fix Your Own Back, is on there. You can find that Dombrowski paper I'm referencing in that particular course. But they showed that it's not a purely sagittal plane movement. There's all kinds of interesting deviation, and it's patient specific too. I mean, it was a very small study. I don't think you can imagine trying to set something like that up. It would be impossible to do a very large cohort, but I think they had 5, 6, 7 patients or something. So what have you done with your models? Show us what you got there.
Let's see here. So, well, here is a 2 through 5. And this disc here has been created with half the stiffness as these two. And with the hyaline cartilage that I've tried to recreate here, you can see the white, it's an elastomeric tissue here. So helping patients kind of understand, oh, okay, that's the cartilage there. Interesting. Okay, so, but with movement, you can see how the one segment moves in excess.
Right.
So, and then I've peeled away the hyaline at that particular level. So if you want to talk about and help the patients understand the movement, the excessive movement, I don't usually use the word instability because, as soon as you use the word instability, people think they're unstable and something's going to fall apart. It's not the case. These are subtle movements. And I also like to help patients understand that these movements are small and it's not like something's out of place. You have these subtle motions that if you have a motion imbalance, and likely due to, like I had a case there yesterday, somebody was, I suspected there's a hypermobile segment. He gets shot down the leg, he gets pain down the leg with certain movements, and he's coming to me and I'm helping with stabilization, through, and it's been very helpful for him. And we just had an x-ray and you can see this excessive, there's excessive osteophytosis at this one particular level, actually 3, 4. So very likely over the course of his life, whenever he bends, there's a focal point, there's a fulcrum at that particular segment, and he just keeps moving. So I have to train him to move a little bit differently to reduce the hypermobility at that particular level. So anyways, I just find that, using the model helps them. Oh, okay. So really it's not that bad. I just have to do this. And if they do the hip hinging or they, move in a better way to not trigger this, all of a sudden they're like, hey, I've seen it. I know what needs to happen. Then I talk about the progression associated with adaptation and changes over time with degenerative disc disease, how this will likely stiffen in time, because often their mindset is like, oh my gosh, am I going, what am I going to look like in the future? Right? When they're laying in bed at night, right? So you can tell them, you know what, in time, you take care of this will likely stiffen and this will reduce in pain. And you know what? Your prognosis is good. So I just find that, using the model really kind of empowers the patient with these movements that aren't that, they have these exaggerated movements in their mind, thinking that something is like way out of place, but they're subtle, right? These are small movements. And
and for those of you that don't know Jerome, this is Dr. Jerome Fryer, and up in Kelowna, points around Kelowna. Where are you?
No, I'm on Vancouver Island.
Oh, you're on the island. What town are you in?
Nanaimo.
Nanaimo. All right.
I was in Ucluelet and Tofino for 7 years, and then we moved to the inside here for our kids.
Oh, far out, man. It's gorgeous country up there. My son did a clerkship over there in I think
Victoria?
No. It was a little town. He did an inpatient or an outpatient internal medicine clerkship. We started with a D. Was it Duncan?
Duncan?
Yeah.
Duncan?
Just a little town.
It's not that little.
Yeah.
Well, that's all a matter of perspective.
Yeah, there's that. But
Right.
yeah, he was over the moon about how beautiful it was up there. But I used to live up on Orcas Island, so I can appreciate the topography of that particular
Nice.
part of the world. You hit on several really germane points there, Jerome, and I know there was a time where you, as the founder and the wizard at Dynamic Disc Designs, you're in your shop, the master at his craft with your dirty vest and everything. I can only imagine you get the same kind of crap from your wife that I get from mine about the work stuff all around the house. But you've gotten a ration of crap at various times over the years about the possibility of
Creating fear, or, fear avoidance, that kind of theme. Yeah, right. Yeah, it was interesting. Yeah, right around the time of the inception of the company, I was like, built it for the purpose of empowering patients and revealing the sources of the potential causes. And then, yeah, it was really interesting. Really interesting.
It is, and it feels to me, certainly in my own clinical practice and in the teaching that I do, but it seems also in the sort of overall vibe of the way that people are talking about pain science and stuff these days, that it's also gotten it's taken it on the chin from some of the major researchers being involved in some huge papers that ultimately found out that, well, it's not all just about pain science. The Traeger paper from Australia was a watershed, and Mosley was a co-author on that. And they were looking at ways to try to demonstrate whether pain science education in patients that had acute low back pain could reduce the progression of acute low back pain to chronic low back pain. And they found in a very well done study that it was no better than the placebo. And the placebo was just general recommendations to be active. So it was some education, but not specifically pain science education. So it doesn't mean that stuff isn't important. It doesn't mean that micro movements of a spine that is dealing with that's not important. It just all needs to be framed as part of a more integrated process. And that's what we are trying to do with NCA. How do we bring the brain and the patient's understanding of their condition, some agency there? How do we bring that into a viable, pragmatic solution to help that patient reduce putative threat to spinal cord, nerve root, elements of their central nervous system, right there next to a segment that's the body's a little bit on high alert about that segment moving too much. It makes me think as well about another patient I had not too long ago that they had prior history of multiple lumbar disc herniations, some pretty marked lumbar disc disease. Patient was an engineer, so very much into a mechanical idea about what was going on. They had previously responded quite well in their lumbar disc herniation to McKenzie extension end range loading. And now any kind of end range extension caused symptoms very specifically into the middle buttock, and palpation, it was not over the sciatic nerve. Palpation, it was kind of over the middle cluneal nerves. So I'm like, do we have some middle cluneal involvement? Yeah, possibly. But you know, the one structure that this paper that Jerome brings to our attention, that we have the poorest sensitivity and specificity for with orthopedic testing are the facets. And, you know, Kemp's seated and standing were positive on him. He could reliably make his symptoms worse with walking, and he could only take about 10 steps before he would start feeling a progressively worsening pain that stayed right in the center of his butt. And I had a difficult time actually palpating in that area and localizing it with palpation. So he subsequently, I sent him out, and he had a facet block, and his symptoms were remarkably better for a week. So they promoted the idea of a medial branch ablation. And this patient, being the type of geek that he is, he did his research on that medial branch ablation. And mind you, he had a spondylolisthesis. It was a grade 1. It was about 4 millimeter slippage. But his point, very well thought out, was if I get that medial branch ablated, that medial branch is not just sensory, it's also motor to the multifidus. Is that going to hasten my listhesis? So, beautiful question, because there was once upon a time, and when Jerome and I were going through school, we were taught that that medial branch is pure sensory. So, but subsequently we've learned that there's motor involved in that medial branch, and when we are ablating it because of the facet, the involvement of the facet, we are also indirectly reducing the motor output to the multifidi. So if we've got that tendency for slippage that the facets are restraining, then it's kind of borrowing from Peter to pay Paul. So.
Yeah, that is so interesting. Thanks for the reminder. That had slipped my mind regarding the motor innervation there. So thanks for the refresher.
Certainly. Okay, well, we managed to talk for another 30 minutes about some interesting topics there. We're coming up on an hour. Does anyone have any questions or comments before we sign off in a few minutes?
Just to say thank you. That was actually really interesting and a really great. Right. I had not actually thought about the motor component of that nerve and the impact of that. So incredibly helpful.
I think that's one that we will. I think all of us, as someone who has experienced lumbar disc herniation in my past, it's part of what got me very interested in all of this. And I was, you know, a smaller subset yet, because mine was an upper lumbar herniation. And then subsequently going through all the DNS material and always being told that I was weird because I couldn't get rid of my open scissors and I couldn't make certain portions of my abdominal region actually fire. The motor for those abdominal muscles, the obliques, coming from the area that I had the disc herniation and a radicular process involving that affected the motor for those muscles. Yeah, and now, after years of really being very careful about trying to manage that lordosis, and I find myself now with more of an extension pattern, and my facets are talking to me under certain times. So it's more challenging now for me to swing a kettlebell, do swings as part of my workout. So you'll see this as many of us get a little bit older, and you'll certainly see it as all of us get a little older and wiser. And you should probably be a little bit suspicious if all of the people that are giving whose information you're following on social media happen to be 20 something or 30 something, and they're giving you all kinds of information about how you should manage a particular issue in your back or in your knee, and such. You should take all of that with a grain of salt, because time tends to make things a bit apparent. There are those online that really coach willy-nilly, going in all the way under load into deep knee flexion as well, which will work really well for some conditions for a period of time. But it's in that position under load that we put the root of the medial meniscus into a maximum compression and then rotation moment. And that's where the blood supply and for the meniscus lives. And that probably will hasten degeneration. There's probably a sweet spot right in the middle of loading like that all of us should pay a bit more attention to. Same thing with lumbar spines. So here's to a good finish on today's coffee club, where we will bang the drum for, we'll call it the middle path, if not mediocrity.
Thanks for all your efforts, Philip.
Yeah, thanks so much, guys, for your time, your attention. This will be up for your review, or for others if you want to share it on the community. Also on my, the recording will also be available on my YouTube channel. You guys be well. Take care. I will see you next week.